Okay, I want you to just picture the room for a second. It's a delivery suite. It's supposed to be this incredible moment, maybe the best moment of a parent's life. The air is just thick with anticipation.
Mm-hmm.
But then the baby comes out, and instead of that big, lusty, life-affirming cry that everyone is waiting for, there's just silence.
Yeah.
And that silence has weight. You can feel it. The baby is limp. Maybe they're a little pale, maybe even blue. The heart rate is way down on the monitor. It is the absolute total antithesis of what everyone in that room expected.
It really is the nightmare scenario. I mean, that's the thing that keeps every single obstetrician, every midwife, every neonatologist awake at night. That transition from, intrauterine life to breathing air.
Yeah.
It's probably the most dangerous journey any of us ever take. And sometimes it just goes wrong.
And for thousands of years, the grandmother's instinct, the doctor's instinct was always the same, right? Warm the baby up, swaddle them, get the heat lamps on, rub their back, keep them cozy. We associate warmth with life, and we associate cold with death.
It makes perfect evolutionary sense. I mean, a cold baby is, in most circumstances, a dying baby. So everything in our biology, everything in our training just screams heat.
Except we have this massive document sitting on the desk today that basically says, stop. Do the exact opposite of that instinct. We are looking at the 2026 clinical report from the American Academy of Pediatrics on therapeutic hypothermia. And the protocol is effectively to chill a newborn baby to save their brain.
It sounds so barbaric if you don't know the physiology behind it. It really does. You're intentionally inducing hypothermia. I mean, you're lowering a baby's body temperature to a level that would normally send an adult straight to the ER in a newborn who is already just incredibly fragile.
It seems so counterintuitive.
Totally. But this isn't some fringe science anymore.
Yeah.
You could argue this is the single biggest success story in neonatal neurology of the last, quarter century.
That is a huge claim. So that's our mission for this deep dive. We're going to decode this whole thing. We need to parse the why. How does being cold actually stop brain cells from basically committing suicide?
Right. The mechanism.
And we have to walk through the recipe because it's not like you can just put a baby in a snowbank. This is incredibly precise.
No, it's precision medicine down to a 1/10 of a degree.
And we also have to look at the dark side of this data, I guess. Why trying to help the wrong babies like premature infants can actually do more harm than good, can even kill them.
And that gets into this whole concept of therapeutic creep, which is so important because when you have a hammer this powerful, this effective for one specific group, everything starts to look like a nail. And in medicine, that is a really dangerous way to think.
Okay, so let's start at the very beginning. Definitions. We need to make sure we're all speaking the same language. We're throwing around terms like HIE and encephalopathy. Are those just synonyms? Can we use them interchangeably?
People do. In the hallway, in the NICU, you'll hear them used that way. But technically, no. And the distinction is actually critical for how we approach treatment.
Okay.
Think of neonatal encephalopathy as the big umbrella term. It's the what. It just means the baby's central nervous system is, for lack of a better term, offline.
It's a description of the symptoms.
Exactly. It describes the state of the patient right now. They're sleepy, maybe they're having seizures, they aren't breathing right, their reflexes are depressed or absent. It's just a clinical description.
Okay, so encephalopathy is the symptom. I see a baby who is not doing well neurologically. That's the observation.
Right. Then you have HIE, which stands for Hypoxic-Ischemic Encephalopathy. That's the Y. It's a specific diagnosis. Hypoxic means a lack of oxygen. Ischemic means a lack of blood flow.
Got it.
So HIE is brain dysfunction that is specifically caused by a suffocation event or some kind of blood flow crash right around the time of birth. It's the cause of the encephalopathy.
But here's the catch that I was reading in the report. When that baby is born, limp and blue, you don't always know for a fact, right then and there, that it was HIE, do you?
That's the crux of the issue.
It could be something else. It could be a stroke in utero. It could be some kind of rare genetic metabolic disorder that just chose birth to crash. It could be a raging infection.
Absolutely. And that's the friction point in all of this. We have this really strict 6-hour clock to start treatment. We can't wait 3 days for a genetic panel to come back. We can't wait a week for a complex metabolic workup.
Because you'd lose the brain by then.
You'd lose the brain. So what we end up doing is treating the encephalopathy based on the strong suspicion that it is HIE. We treat the fire before we found the exact match that started it.
Because waiting to be 100% certain just means it's too late?
Correct. If we wait for 100% certainty, we lose the very thing we're trying to save.
The report leads with this one number, and it stopped me in my tracks. It says that in high-income countries, if you cool these babies correctly, according to the protocol, you reduce the risk of death or major disability by 25%.
25%. I mean, just sit with that for a second. In medicine, we usually fight for single digits. A new cancer drug might give you a 3% survival benefit, and it's hailed as a breakthrough.
Right.
A 25% reduction in things like severe cerebral palsy, cognitive impairment, or just death. That is astronomical. It's a statistical mountain. It's one of the most effective interventions we have in all of pediatrics.
They mentioned the number needed to treat, the NNT. It's between 6 and 7, which, if I'm understanding it right, means you cool 6 or 7 babies who qualify and you statistically save one entire human life from a catastrophic outcome.
Yes. And think about the return on investment on that. Not just financially, which is enormous, but in terms of human suffering. That's a child who walks instead of using a wheelchair for the rest of their life. A child who learns to talk, who goes to school, who goes to college. The impact is just, it's profound.
Okay, so let's get mechanical. Let's get into the science of it. How does the coal actually do this? You know, if I bang my knee, I put an ice pack on it to stop the swelling. Is this just a really sophisticated whole-body ice pack?
It's so much more elegant than that. And to really understand why cooling works, you have to understand the injury itself. And the key concept here is that the injury isn't an event. It's a process. It unfolds over time.
Okay, break that down for us. What do you mean it's a process?
All right. So phase 1 is the primary injury. Let's say the umbilical cord prolapses or the placenta detaches completely. Oxygen gets cut off from the brain.
Right.
In that moment, cells start to die because they're starved of energy. That happens within minutes. We cannot fix that. The cells that die in that initial insult,
Right.
they're gone.
So that's the initial hit. The match has been struck.
Exactly. But then the doctors, the nurses, they resuscitate the baby. The heart starts pumping again. Oxygen starts flowing to the brain. We get what's called reperfusion. And this is the paradox. This is what sets off phase 2.
And this is the part that just feels so unfair. The blood coming back, the oxygen coming back, that actually causes more damage.
It's a cruel biological trick. It really is. The restoration of oxygen to those stunned, injured cells triggers a massive inflammatory cascade. You get a flood of free radicals, these unstable molecules that just tear apart cell membranes.
Okay.
You get something called excitotoxicity. An amino acid called glutamate floods the brain, and it basically overexcites the neurons to death. It's like revving an engine until it blows.
Oh.
And maybe most importantly, you get apoptosis.
Apoptosis. That's programmed cell death, right? Cellular suicide.
Exactly. It's cellular suicide. So the cells that actually survived that first hit, that initial lack of oxygen, they sort of look around at this toxic inflammatory environment, and their own internal programming decides, this is not a viable situation, I'm shutting down. And they initiate a sequence to die.
And this is happening hours, even days after the baby has been born and is breathing again?
Yes. This is the key. That secondary wave of injury doesn't peak for 24 to 72 hours, and that delay. That is our opportunity. That is the therapeutic window.
So that's where the cooling comes in.
That's where it comes in. Hypothermia acts as a kind of universal pause button. It dramatically slows the metabolic rate of the brain. The cells just need less energy. It suppresses that inflammatory cascade. It helps block the release of those excitotoxins. It basically sends a signal to all those cells that are on the brink of apoptosis and says, hey, don't commit suicide just yet. Just chill out, literally. Wait for the cleanup crew to clear out all these toxins.
It's buying time for the brain's environment to stabilize.
Precisely.
Yeah.
It's buying precious time. But the report is very, very clear on this, and it's based on decades of animal data.
The piglets and fetal sheep studies they mentioned.
Right. All those studies showed that if you wait too long, if you go past about 5.5 or 6 hours, that destructive cascade becomes a runaway train. Yeah. The apoptosis pathways are locked in. At that point, the cooling doesn't work anymore. You've missed your shot.
Hence, the incredibly strict 6-hour initiation rule.
The clock starts ticking at the moment of birth. Not when the baby gets to the NICU, not when the transport team arrives. At birth, every minute counts.
So let's talk about the recipe then, because if I'm a neonatologist standing there, I'm not just guessing at the temperature. This has to be military-grade precision. What is the standard of care?
We follow the protocols that were established in the big 3 historical trials. You'll hear them called the NICHD trial, the TOBY trial, and the CoolCap trial. They all converged on a very similar recipe.
And what is that?
The target is a core body temperature measured with a rectal probe of 33.5 degrees Celsius to 34.5 degrees Celsius.
Which is, what, roughly 92 degrees Fahrenheit for those of us thinking that way. So we're dropping them about 4 degrees Celsius, maybe 7 degrees Fahrenheit below normal.
It doesn't sound like a huge number, but for a homeothermic mammal, that is deep. It's a major physiological shift. And you keep them there rock steady for exactly 72 hours.
3 full days.
3 days. Not 70 hours, not 75. Exactly 72.
And then what? You can't just switch the heater back on, right?
Well, no, absolutely not. Then you start the rewarming. And this is a place where people used to mess up all the time. You have to rewarm them incredibly slowly. The standard is 0.5 degrees Celsius per hour.
Half a degree an hour.
Yes. So it takes almost a full nursing shift. We're talking 6 to 8 hours
Okay.
to get them all the way back up to a normal temperature.
Why the snail's pace? What happens if you warm them too fast?
Big problems. If you rewarm too quickly, the blood vessels can dilate rapidly all over the body. You can cause severe hypotension, a blood pressure crash. But the even bigger concern is in the brain. Rapid rewarming can be a massive trigger for seizures. You can literally undo all the neuroprotection you just fought so hard for over the last 3 days.
So, human nature being what it is, I have to assume that somewhere along the line, some smart person thought, well, if 72 hours is good, maybe 120 hours is even better. If 33.5 degrees is good, let's try 32.
The more is better fallacy. It is pervasive in medicine. And you're exactly right. They tested it. The NICHD network, which is sort of the gold standard for these big neonatal trials, ran what they call the optimization trial.
Okay.
They took a group of babies with more severe HIE, and they randomized them to either the standard protocol or a longer, deeper one. 5 days of cooling instead of 3, and a target temperature of 32.0 degrees instead of 33.5.
And I'm guessing, since we are still sticking to the old protocol, that it did not go well.
It was a disaster. It's one of those trials that got stopped early by the Data Safety and Monitoring Board.
Stopped early, that's never a good sign.
It's the sign that you're either causing harm or there is absolutely no chance of finding a benefit, and it's unethical to continue. In this case, they found futility. It wasn't helping at all, and they had significant safety concerns. The in-hospital mortality rate in the longer, deeper cooling group was actually higher than in the standard group.
So it's actively harmful.
It was. There appears to be a Goldilocks zone.
Just right.
Precisely. If you go too cold for too long, you start to see other systems fail, you can crash the heart rate too much, you can suppress the immune system so much that they get overwhelming sepsis, you can interfere with blood clotting and cause bleeding. So 33.5 for 72 hours, that's the biological sweet spot. Our advice is, don't freelance. Stick to the recipe.
Okay, so we know how to cool, but the much harder part, it seems, is deciding who to cool. The report has this incredibly complex flow chart, figure 1. It looks like a tax form, but I guess every box is a life or death decision.
It is. It's a decision matrix, and it's designed specifically to stop us from hurting babies. Because you have to remember, cooling is not benign. It means being in an intensive care unit, often with sedation, maybe on a ventilator with central lines. You do not do this to a healthy baby.
So let's walk through the gates on that flow chart. Gate number 1 is age.
Gestational age. You have to be 36 weeks or greater, strictly term or late preterm infants.
And we'll circle back to why preemies are so strictly excluded, because as you said, that's a whole horror story in itself.
Yes.
Okay, so you're at least 36 weeks. Gate 2 is the biochemical evidence. You need proof something bad happened.
Correct. We need some objective proof of a significant intrapartum stress. The classic finding is acid in the blood. We look at a cord blood gas or a gas within the first hour of life, and we're looking for a pH of 7.00 or less.
And for the non-medical listener, normal pH is around 7.4, and the scale is logarithmic, so 7.0 is incredibly profoundly acidic. It means the baby was essentially suffocating, and all that carbon dioxide and lactic acid built up to really dangerous levels.
That's a great way to put it. Or we can look at something called the base deficit, which is another measure of that acid load. We look for a base deficit of 16 or more.
What if you don't have the blood gas? What if it got clotted or something?
Good question. Sometimes you don't have it, or maybe it's borderline, say a pH of 7.1. Then you can use a combination of other factors. You look at the history. Was there an acute sentinel event? Did the uterus rupture? Did the cord prolapse?
A clear catastrophe.
Right. And you combine that with low APGAR scores, specifically an APGAR of 5 or less at 10 minutes of life, plus the fact that the baby required significant resuscitation, like intubation and positive pressure ventilation, for at least 10 minutes.
So story plus bad scores plus needing a lot of help.
Right. That combination can get you through gate 2.
And that brings us to the final gate, which the report seems to say is the most important one of all.
The clinical exam.
Yeah.
The neurological exam. We use something called the SARNAT exam. The bottom line is you have to prove the baby is actually encephalopathic. You cannot just treat a number on a piece of paper.
The report has a whole table for this, Table 1. It divides the encephalopathy into moderate and severe. Can you just paint the picture for us? What does a baby with moderate encephalopathy look like?
A baby with moderate SARNAT is lethargic. They're just not with it. You stimulate them, they might briefly respond, but then they just drift off again.
Nah.
They're floppy. The word we use is hypotonic, like a little rag doll. Their hands might be open instead of fisted. Their suck reflex is weak or absent. And crucially, their pupils are often tiny, constricted, like kin points. They might have periodic breathing where they take a few breaths and then pause for a few seconds.
Okay, so that's moderate. What about severe?
Severe is a big step up. Severe is a stuporous or comatose baby. They have basically no spontaneous activity. They are flaccid, just completely limp. No response to even painful stimuli. All their primitive reflexes, like the moro or the suck, are absent. Their pupils are often dilated and fixed, not reactive to light. And they usually aren't breathing on their own at all. They are apneic.
And to qualify for cooling, the report says you need findings in at least 3 of those categories on the exam.
Yes, you can't just have one thing. You need a constellation of findings that points to significant brain dysfunction.
Now, here's the nuance that I think probably trips a lot of people up. Let's create a scenario. You have a baby who is born, and the cord gas comes back with a terrible pH, say 6.9, a really scary number.
They're very scary.
But 30 minutes later, you go to the warmer, and the baby is looking at you, they're crying, they're moving all 4 arms and legs vigorously. The exam is normal.
You do not cool that baby.
Even with that pH of 6.9.
Even with the pH of 6.9, a normal exam trumps everything. If the exam is normal, it means the baby's brain compensated. It withstood the hit. The risk of sedating, intubating, and cooling that baby far outweighs any potential benefit. You treat the patient, not the lab value.
On the flip side of that, the report makes a point of busting a myth, something they call the sentinel event requirement.
Yeah, this used to be a real barrier to care. Some doctors felt they needed a smoking gun. They wanted to see the true knot in the umbilical cord, or they needed confirmation that the placenta abrupted. If they couldn't find the obvious accident, they were hesitant to initiate treatment for the injury.
But the AAP is saying that's a dangerous way to think.
It's very dangerous because sometimes the event happens silently, inside. Maybe the placenta just started to fail over the last hour of labor, or the cord was compressed intermittently in a way no one could see. The point is, if the baby meets the biochemical criteria and the exam criteria, you treat. If you spend 4 hours hunting for the definitive cause, you've missed your therapeutic window.
Okay, I want to pivot now to what you called therapeutic creep. It's such a great term for what seems like a very dangerous behavior. We see a treatment that works wonders for Group A, so we start to slide it over to Group B, just assuming it will help them too.
It happens in all of medicine, but I think in neonatology, the stakes feel so much higher, and the desire to do something is so powerful.
And the biggest area of creep, according to this report, seems to be the late preterm baby, the 34, 35-weeker. They look a lot like term babies, just a little smaller, a little scrawnier. It must be so tempting to cool them if they've had a bad birth.
It is incredibly tempting. They look like they should benefit, but this is where the AAP report just drops the hammer. They are unequivocal. They cite a specific, well-done, randomized controlled trial of cooling in 33 to 35-week infants. And the results were sobering.
What did they find?
Not only did cooling fail to reduce the rate of death or disability in this group, it showed a high probability of increased death.
Wait, the treatment. The treatment might have killed them.
The point estimate for mortality was higher in the cooled group. It was trending towards harm. The trial was stopped because of that signal.
Why? I mean, what's the difference? Why does a 36-weeker's brain get saved by the cold and a 34-weeker's brain gets harmed?
It comes down to physiology and brain development. A 34-week brain is structurally different and much more fragile than a term brain. There's an area deep in the brain called the germinal matrix, which is rich in blood vessels, and it's extremely prone to bleeding in preemies.
Okay.
And we know that cold messes with clotting factors. It makes you more likely to bleed. So you cool a preemie, and you might be inadvertently triggering a massive intraventricular hemorrhage, a brain bleed. On top of that, they just have less metabolic reserve, less brown fat. They can't handle the physiological stress of the cold in the same way.
So the line in the sand is 36 weeks. And it's a hard line.
Do not cross it. The evidence is clear. You risk harming them.
Okay, so that's one gray zone. The other one the report spends a lot of time on is mild HIE. We talked about moderate, which is the lethargic baby, and severe, which is the comatose one. But what about the baby who isn't lethargic? They're maybe hyperalert, jittery, their eyes are wide open, maybe they have a really exaggerated startle reflex.
The milds. This is probably the biggest controversy in the field right now. These babies don't meet the classic criteria for cooling from the original trials. But we have follow-up data showing that some of them, maybe 15%, maybe up to 20% in some studies, will go on to have long-term problems. ADHD, learning disabilities, executive function problems, they're not fine.
So doctors are starting to cool them just in case. Is that the creep?
That is the creep. The report notes that in some large registries, nearly 80% of babies classified as having mild HIE are now getting cooled. It's become almost routine in some centers.
But what does the evidence say?
The evidence isn't there yet. We simply don't know if the benefit of cooling these babies outweighs the harms. And there are harms. Separation from mom during a critical bonding period, sedation, the stress of the ICU.
So what's the recommendation?
The report mentions that several large trials, like the COMET trial and the COOL Prime study, are underway right now to answer this exact question. Until those trials read out, the official AAP recommendation is, do not make this your standard of care. If you're going to cool a baby with mild HIE, you should be doing it as part of a research protocol. Otherwise, you risk overtreating thousands of babies who would have been perfectly fine without it.
Okay, another gray area is the time window. What if the baby arrives at the big cooling center at 8 hours old? They missed the 6-hour cutoff. Is it just too late?
That's the late presentation dilemma. There was a big trial that looked at this, cooling babies between 6 and 24 hours of life. The results were murky. There was a possible small benefit, but it wasn't a slam dunk like the under 6-hour data.
So what's the guidance?
The AAP says it's not standard of care, but it may be considered. And the key phrase they use is that it requires shared decision-making with the parents. It's a very careful conversation where you lay out the uncertainty. It's not an automatic yes.
Let's shift gears to logistics. You mentioned that keeping a baby cold isn't just about ice packs, and this becomes really critical during transport.
Right. Most of these babies are not born in a hospital that has a cooling program. They're born in community hospitals, and they need to be transferred to a regional level 3 or 4 NICU. That transport can take hours by ambulance or helicopter.
And the report has this strong warning against what it calls passive cooling. What is that, and why is it so bad?
Passive cooling is basically just turning off the heater on the transport isolette and hoping for the best.
That sounds imprecise.
It's a total gamble. Babies are small. They have a huge surface area to volume ratio, so they lose heat incredibly fast. If you just turn off the warmer, they can easily overshoot the target and plummet down to 32 or 31 degrees. That's where you get serious cardiac arrhythmias and bradycardia.
So what's the alternative?
What you need is servo-controlled cooling. You need a machine, a cooling blanket, that's connected to the baby's rectal temperature probe. The machine reads the baby's temp every second and adjusts the temperature of the water flowing through the blanket moment by moment to keep them exactly at 33.5. It's active, intelligent regulation.
And on the flip side of getting too cold, the report just screams about avoiding hyperthermia, getting too hot.
This is a huge, huge point. If you are in a situation where you cannot cool the baby safely, your #1 job is do not let that baby get hot. A fever in an injured brain is like throwing gasoline on a fire. It accelerates all those destructive metabolic processes.
Wow.
The data is shocking. For every degree of fever a non-cooled HIE baby has, their risk of death or severe disability jumps 3- to 4-fold. So just preventing fever is, in itself, a powerful neuroprotective strategy.
I want to geek out on the pharmacology for a second because this was one of the most fascinating parts of the report for me. The idea that a cold body processes drugs in a completely different way.
It makes sense if you think about it. It's basic chemistry. Temperature affects the rate of all chemical reactions, and it also profoundly affects organ function. In a cold baby, the liver enzymes that metabolize drugs slow way down, and the glomerular filtration rate in the kidneys drops significantly.
So if you give a standard dose of a pain medication, like morphine,
the liver can't clear it at the normal rate. The drug's half-life gets much, much longer. So if you give a standard dose, and then you keep giving it on a normal schedule every 4 hours, the drug just stacks up and up and up. You can very easily and accidentally overdose the baby. They can stop breathing, their blood pressure can tank.
And the same thing would apply to antibiotics.
Gentamicin is the classic example. It's an antibiotic that's cleared almost entirely by the kidneys. In a cool baby, we have to stretch the dosing interval. Instead of giving it every 24 hours, we give it every 36 hours. If you don't make that adjustment, you can build up toxic levels that fry the kidneys and cause permanent hearing loss.
There was one specific drug interaction in there that felt like a logic puzzle. Phenobarbital and midazolam.
Oh, the CYP3A4 trap. Yes. This catches residents and fellows all the time if they're not careful.
Okay, explain it.
So, phenobarbital is an old-school seizure medication. One of its properties is that it's a powerful inducer of liver enzymes, specifically an enzyme called CYP3A4. It basically makes the liver work faster to chew up certain other drugs.
Got it.
Midazolam, which is a sedative we sometimes use, happens to be a drug that gets chewed up by that specific enzyme.
So if a baby is on phenobarbital, their liver is just burning through the midazolam really fast. You need a higher dose to get the same effect.
Exactly. But now, let's say the seizures stop after a day or two,
Oh.
and you decide to stop the phenobarbital. The induction effect on the liver wears off. The enzymes flow back down to normal, but you're still giving that same high dose of midazolam. All of a sudden, the liver stops clearing it effectively. The midazolam levels can spike to toxic levels, and the baby can become oversedated or hypotensive.
You really have to play 4D chess with the medication list for these kids.
You have to be thinking constantly about the physiology of the cold, not just the name of the disease.
Speaking of seizures, the report mentions something that's frankly terrifying. The idea that you could be looking at a baby who is perfectly still, looks peaceful, but inside their brain is on fire.
Electrographic-only seizures, or non-convulsive seizures. It's a huge issue. About 50% of these cooled babies will have seizures, and in many of them they have no physical symptoms at all. The electrical storm in the brain has become uncoupled from the motor output of the muscles.
So if you don't have an EEG hooked up to the baby's scalp,
You are flying completely blind. You think the baby is stable, but they are having seizure after seizure, burning through energy reserves and losing neurons by the minute. Continuous EEG monitoring is not optional. It is mandatory in this population. You cannot guess.
it seems like we've gotten so much better at the medical side. I want to pivot now to the parents. I just can't imagine the trauma of this. You expect a healthy birth, and in a flash, your baby is whisked away to an ICU, covered in wires and tubes, and when you finally get to touch them, their skin feels cold.
It is a profound suspension of time and reality for them. It is acute grief. And for a long, long time, the medical establishment, with the best of intentions, probably made it worse. We had this very hands-off approach. Don't touch the baby, don't overstimulate, the baby is critical.
But the report suggests we've moved past that now.
We have. There's a huge emphasis now on trauma-informed care and family-centered care. We now have good data showing that you can hold a cooling baby. It's logistically awkward with the cooling blanket and the lines, but it's safe and incredibly important for bonding.
Can they feed the baby?
Yes. We encourage what are called trophic feeds, just tiny drops of mom's colostrum or milk given into the mouth. It doesn't provide nutrition, but it keeps the gut healthy and primes it for later. We have to treat the family bond and the parental trauma just as aggressively as we treat the neuronal injury.
And finally, there's the question every single one of these parents asks, probably 100 times a day, is my baby's brain going to be okay? When do we actually stand them to find out?
The timing of the MRI is everything.
Yeah.
And the report has a very strong warning about a phenomenon called pseudonormalization.
That sounds deceptive.
It is. The cooling process itself affects how water moves in and out of brain cells. If you do the MRI too late, say on day 10 or 12, the initial swelling might have resolved, but the permanent scarring from the cell death hasn't fully shown up yet. The scan can look falsely reassuringly normal, and you give the parents false hope.
So when is the right window to do the MRI?
The sweet spot is either early, on day 4 to 5, right after the rewarming is complete, or you wait until after day 14, when the patterns of permanent injury have become clear. Do not scan in that middle zone between, say, day 8 and 12. You will get bad, uninterpretable data.
We have covered a massive amount of ground here. I mean, from the molecular cascade of apoptosis all the way to the decision matrix of the SARNAT exam and the logistics of transport.
I think the headline is really clear. Cooling works. When used for the right baby at the right time, it saves 1 in every 6 or 7 treated babies from death or severe disability. But you have to follow the rules.
33.5 degrees.
for 72 hours.
Within this 6-hour window.
And absolutely no preemies.
But as we close out, I want to leave the listener with this one thought that came up at the very end of the report. It's a bit of a provocative question about why this works so well.
The fever hypothesis.
Exactly. So we know cooling to 33.5 degrees helps, but we also know from all that other data that for every single degree of fever a baby with HIE has, their risk of a bad outcome jumps fourfold.
Fourfold. It's an incredible number. Fever is just unbelievably destructive to an injured, vulnerable brain.
So the question the experts are now quietly asking is this. Is all the magic coming from the cold, from being at 33 degrees? Or is a huge chunk of the benefit simply coming from the fact that by using this technology, we are strictly and obsessively preventing them from ever getting to 38 degrees?
Are we rescuing them with the cold? Or are we just protecting them from the heat?
Exactly. And that's actually a really empowering thought, isn't it? Because even if you're in a hospital in a low-resource setting that can't do the full high-tech servo-controlled cooling protocol, you can fight the fever. You can keep that baby normothermic. And that simple act alone might be 80% of the battle.
It might be. It really shifts the focus from a magic technology to just excellent, stable physiological support.
A truly fascinating deep dive into a protocol that completely changed the landscape of neonatal medicine. Thank you for walking us through it.
My pleasure. Stay cool.
To our listeners, thank you for being with us. We'll see you on the next deep dive.